Rah boy, I'm not going to lie. Zimbabwe ain't having a bar of it. So America offered them a health deal worth about $367 million over a 5-year period. And they were like, you know what, actually, we're going to pass. The talks have now collapsed and the US says it will wind down health support. And that matters because since 2006, the US put nearly $2 billion into Zimbabwe's health system. Donors have funded the vast majority of Zimbabwe's HIV response for absolutely years. And in 2024 alone, roughly $362 million was committed to that program. So let's be clear. Accepting the deal would definitely have meant short-term stability for treatment and breathing room for the budget and continuity for clinics and patients. That's the upside that's visible, right? But we have to be realistic. Funding at that scale also comes with conditions, reporting standards, and long-term dependency questions. And sovereignty over your health systems matters, right? Health data, treatment policy, procurement decisions. These are core state functions. No serious government voluntarily hands over that lightly. So the instinct to protect control is not irrational. Now, here's the balance sheet reality, right? Zimbabwe's already behind on over $7 billion in debt repayments, and public debt sits around 70% of GDP with limited access to international capital markets. Replacing donor funding isn't a pride issue. It's about what the numbers can carry. Zimbabwe does actually already have a national AIDS trust fund, which is funded partly through a 3% levy that proves domestic ring fencing can actually work. But scaling that up would be politically painful. Revenue reform is hard. Tax compliance is uneven. Mineral income is volatile. And now that the deal has collapsed, the first priority must be continuity. Protect drug supply chains, ring-fence HIV procurement, secure bridge funding if necessary. Patients cannot be the shock absorbers of strategic decisions. Then comes the harder part, right? What percentage of total health spending depends on donors? What is the immediate funding gap this year? And what is the 5-year plan to increase domestic funding without further destabilizing care? This is where sequencing matters, right? If we look at Botswana, they manage diamond revenue carefully over time. Norway ring-fenced oil wealth over decades, not overnight. You do not reject support first and then design the system later. So I'm hoping they have something in place, right? Because what you need to do is phase the transition. Independence is more than just like a speech and something that everyone claps at. It is a funding model. The real test isn't saying no, it's showing what replaces it. Anyway, let's talk in the comment section. What are your thoughts? Did they make the right decision? Anyway, make sure you share, comment,